I want to thank Jim Dubell, okay, for putting this on, for having us here, for having us grow and join together. You know, he's an amazing, kind, loving spirit. Okay, the other day, he was in a bank up here. He was walking in the lobby of the bank, and he notices this little old lady, and she's sitting there, and she's going through her checkbook, and she's going through her stuff, and she's having all kinds of problems with this. And he goes to her, he says, "Can I help you?" And she looks at him, she says, "Can you help me with my balance?" So he pushes her over. That's Jim. He's always caring and right there for people, okay? So today we're going to talk about some pediatrics. We're going to talk about pediatrics mixed in with philosophy, and talk about a few things along the way with it, okay? I was very fortunate. I never got into pediatrics when I started chiropractic. I was into chiropractic. I was into correcting subluxations, and I was into families. I wanted to see families. In our office, we never counted really visits, we counted family visits in the office and things like this. When I came back to Atlanta, when was that? 91, 92, and I met up with Larry Webster. Larry said to me, he said, "I'm starting a new program for the ICPA. And he said, I want you to be teaching on the program." And I said to him, "Why, Larry? I'm not a pediatric expert." He said, "We had a big practice out in Arizona, didn't you?" I said, "Yes, I did. Hundreds of families and stuff like this." He said, "How many kids' visits do you think you had a week?" So we kind of figured it out, and figured out I was seeing about 200 children patient visits a week. He said, "You understand you're seeing more kids than the experts are?" And I said, "I never thought about that." But that's, you know, that was it. So I want you on the program. So I love it working with kids because like Jay did last night with the dogs and with the animals, you know, I love it when people say, "It's all in your mind. If you think chiropractic works, it's going to work for you." Yeah, ask the animals and ask the babies if it was in their mind. Okay? It's a law, it's a rule. Chiropractic is developed on a three-legged stool, right? Philosophy, science, and art. Now, I happen to think that there should be another three-legged stool right beside that three-legged stool. Because you have the philosophy, science, and art, and on this three-legged stool, okay, you have common sense, love, and passion. And that's where the success comes, okay? I have a lot of people who, you know, have a great understanding of the science, understanding of the philosophy, understanding of the art. I'm thinking about one person in my mind. This guy was the greatest adjuster I have ever seen, right? He was a phenomenal adjuster, right? Failed at 3 practices. He had the personality of a clam. You got to relate. You have to have that love. You have to have that passion. And you have to have the common sense that goes along with it. So have you ever met some of these people who are real good book-learned people, but they can't tie their shoelace? Or something like this? You got to have a balance with all that. So, and what I'm going to present today is we're going to talk a little bit about vertebral subluxation analysis for newborns. Every time we've taught people about this, if I've been on the road teaching, you always get this thing about, "I love kids, but you know, I'm afraid to adjust them because I don't know if I'm finding the subluxation or not." All right, so let's talk about that a little bit. Oh, and I got to interject a couple things here before we even start. You go on this Facebook posts, you see these things, and people ask questions, and it's all symptomatic stuff, right? "I have a baby with reflux. Nothing's helping it. What can I do for the reflux?" Now, at first, I used to think, well, you know, they're asking questions, fine, you know, this kind of stuff. But, and I'm thinking the obvious, right? Well, they must have been correcting and checking this vertebral subluxation. And I realized after talking to somebody, no, No, they're not even looking at that, right? And they go, and then when they have, oh yeah, no, we've adjusted the baby once. Once, we've adjusted the baby. What am I doing wrong? You don't understand chiropractic, that's what you're doing wrong. Okay? Someone said to me, what kind of a program do you put a child on? He said, I start my kids off at once a month. I said, really? Your child has been through the biggest trauma they've ever been through their entire life, and that is birth. And you're going to start them at once a month. No, you don't. You see them every other day or every day, whatever you need to, until they hold the adjustment, and then you limit them from there, promote them from there with that. And everybody's different. Okay? A 10-year-old comes in, you're going to start them at once a month when they had a tremendous trauma 10 years ago that's been in their system? No, you don't. You see them as often as you need to. Promote them accordingly. Don't adjust them if they're clear, obviously. Okay? But find and correct for the subluxation. And quit having attachments to outcomes. Quit having attachments to outcomes. I learned that from Sisyphus a long time ago. All right? Because our outcome and their outcome may be two separate different things. Quit having attachments to outcome. Do your job. Do what you need to do with them. You know, we have a wonderful time at Sherman College. I got to talk about this. We'll sometimes go breakfast. Brian, where are you? There he is, okay. We'll go have breakfast in the cafe there, you know, and Brian Dooley will be there, myself, Ron Castellucci, and Bill Deccan, okay, and Christopher Kent. We're sitting there having breakfast. You know, and students don't even know how they should be there sitting in and listening to this, okay? Because we have a great group, and I've learned so much from it myself, and all of us together with this. It's just a great time to have that. Imagine having it being a mouse in there. Listen to some conversations. Usually our conversations are a little more jovial than I'd say philosophical, but the philosophy always comes in with that. But we have a good time with it, okay? So let's talk about this. Verbal subluxation analysis for newborns. Okay, first of all, your initial contact. I like to say with an initial contact is you want to establish an innate connection. You want to get connected to the child, okay? Do you ask the child for permission to touch them first? How do you do that? You ask them. I'm here to check your nervous system to make sure there's no interference. Are you okay with that? I don't care if they're 2 months old. Okay? You ask them that. You look them in the eyes. If you can't see God in their eyes, something's wrong with you, not them. All right? You look at the child and make that connection. You know, I've had a lot of moms say to me, I don't get it. My child never goes to a stranger. But they come up to you and just reach out for you. Why? And so I'd say something like, well, they know who their real father is. Okay, which sometimes it gets me in trouble, you know, but that's, you know, we have fun with that. No, they understand that I understand who they really are, okay? And we look at them that way, okay? Now, how do you approach a child? First of all, I always like to have the parents, whoever, they're holding the child. If they're little, if they're 2, 3 years old, 4 years old, and they're tiny, right by with the parents, okay? You may think you're very gentle and caring, okay? I'm about 5'7", not very tall, but to a 2-year-old, I'm a giant. Do you know how scary it is for a giant to come towards you with their hands going for your neck like this? That's the way it looks to a child. When you approach a child the first time, approach the child palms up. Submissive position. Palms up. Right, Jay? When you see a dog for the first time, we don't come at the dog like that. Same thing. Palms up. Like that. Be gentle. Be loving. Be caring. Okay, initial contact, approach child with palms up. And example, I'm now going to check you for verbal subluxation so we can make sure that your nervous system is functioning as good as it can, period. We're not checking you for colic. We're not checking you for ear infections. We're not checking you for any symptom. We're checking you to make sure that your nervous system is functioning the best it can. Why? Because your nervous system, if it's functioning better, you'll function better on all levels. Okay? Observation. Next thing we're going to do is going to observe. Taking a look at the child before you even touch them. Are they in distress? Do they need some other help as well as what you're going to do? Is there an emergency situation that needs to be taken care of? Here's how I break it down. Is there an emergency situation that they need some medical or emergency care now? Is there a situation where we can still work with them, but you still want them to have some other care as well? Or is there a situation where we can co-manage this with another doctor easily enough? Or is it a situation where let's just get them adjusted? Okay, you have to make that little determination first. There's observation here, okay? Whoop, wrong button. This button. Okay? Is their head shaped weird? Are they in distress? Is there bruising? Is there trauma associated with them? Take a look at that first. Okay? Look at their head carriage. Are they constantly facing to one side? Flexion, extension. Okay? Could there be an occiput possible issue with that? Look at head tilt. Is their head tilting to one side or another? Could there be an atlas involvement with that? Okay, these are just observations you make initially with a child. It doesn't take very long to do that. Signs of increased intracranial pressure, the head being not symmetrical. Also looking at the eyes. Okay, if the eyes aren't level, if one eye is physically lower than the other eye, there can be increased intracranial pressure on that side. What's going on with that? Okay? I learned stuff now that I wish I had known 40 years ago or whatever. My son, when he was real little as a baby, used to be a headbanger. He used to like to go up against the wall and hit his head against the wall. Okay, sometimes then when he got hurt, he'd put a pillow up there and hit his head against the wall, right? Now I would adjust him, that's fine. Okay? But is that a sign maybe of no CSF flow? And he's trying to get his CSF to flow with that by headbanging? Okay? And we worked on him, we adjusted him and his atlas, and he did fine. He quit the headbanging and stuff. But you know what he wound up with? No sense of smell. No sense of smell. Classic sign of intracranial pressure. No sense of smell with that. Okay? So there's a lot of things I wish I knew then that I know now. Okay? Observation with the kids. Do you love them? Do you care for them? Okay? Are they a number in your practice? No. Don't do that. Arm and leg carriage. Here's a neat one. A little baby, you lay them on their back, a newborn up to 3 months of age, and if they're laying there with one arm flexed in here and one arm flaccid and extended, do you think there might be a brachial plexus involvement with that? Yeah, exactly. Right there. You look at that. And I remember teaching this at a school out in California. I'm not going to mention which school, but one of them out in California. And I talked about that, and they said, brachial plexus, what would you do for that? I said, how about check for subluxation and correct it? Okay? I love the way some of the people are. I'm sorry I'm ranting a little bit, but I get one chance a year to rant, so that's what's going to happen here. Okay? Had a young girl at one of the schools, and she had just graduated. She came to me, and she said, I'm failing in practice. I said, I need help. I'm failing in practice. I said, okay, let's start from the beginning. Explain what you do on your first visit. Well, she says, I do this exam, and went through this whole exam. It didn't sound too bad. Okay, probably not what I would do, but still not too bad as far as an exam is concerned. Then she said, and then I gave the patient an acupuncture treatment. I sent them home, and they came back the next day, and they were still in pain. So I referred them to a medical doctor. I said, well, great. It's a man, I can't even imagine you're in practice at all. If that's the way you're running it. Okay? No. No, 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 no. How about find the subluxation and work on correcting that and correct the subluxation so that the body can maintain that correction, which doesn't mean you do it once. Okay? Yeah, we did. I know we had, B.J. Palmer was adjusting people back, 50, 60 years ago, and somebody would say they'd hold an adjustment for 6 months after. Fine, great, yes, I understand that. Okay, we have a lot more stress and things going on in our lives today. We walked a lot more 50, 60 years ago. We took care of ourselves better than we do now. Okay? So that's one of the things. How about this? Look at the legs. You get a child, their legs are supposed to be flexed and symmetrical, newborn. All right? You get one leg extended while the other one's flexed. That could be a sign of hip dysplasia, things like this. It could also be a sign just of a posterior ilium on that side. You get both legs extended and rigid. That's another sign of increased intracranial pressure with them. These are little things you can see. One of the most common things, so here's some more observation, okay? Look at the gluteal folds. The gluteal folds of this part, the gluteal folds under here, okay? You see a deeper or lower gluteal fold on one side than you see on the other, that's usually a sign of a PI ileum on that side, okay? You see baby fat stuff. How about these things? Okay, you can't really see it on this. But this baby has more folds on its thigh here on the right side than it does on the left. Okay, that's also a sign of a PI ileum on that right side when you have more folds like that. Okay, look at the gluteal crease, squeeze the buttocks, look at the top of the gluteal crease. It'll deviate toward the side of an AI sacrum. Okay, these are easy things to figure out on a child. What I always loved to do was take a newborn, and I may have this in here, let me see. Now we'll go on to it in a second. I take a newborn, lay them prone on the table with no face piece, right? And what I'm doing there is I'm looking for the symmetry, arms, legs, right? And they'll turn their face to one side or the other, okay? If they turn their face to the right, the thoracic spine should curve to the left. Normal. If the thoracic spine doesn't curve the opposite way, guess what you may have there? You might have an upper thoracic, lower cervical problem. And usually you'll find that with a C-section baby, right? Because the way they're extracted from birth, you can get that problem quite a bit. Okay? So you see that it's normal. Fine, normal. Everything looks normal. You take the baby's head, which is turned to the right. You take the head and rotate it to the left. Okay, you know what's going to happen? At first, the baby should, give it about 8 to 10 seconds, the baby will adapt. It'll turn their head to the other side, the thoracic spine should curve the other way. But what happens most of the time when you do that? You turn to the left, baby goes back to the right. You turn to the left, baby goes back to the right. There's a left upper cervical involvement going on there. It will not turn its face toward the side of involvement. And it could be occiput, it could be atlas, it could be axis. Anything in there, okay? Look at that. And then I love when I do this with the parents, and these are the parents who are kind of thinking whether the baby should even have care or not, Babies, they're not bleeding out their eyeball, so they should be fine. And so what happens is, we turn and they turn back and they turn back. And the mom says, you know what? The baby always does turn to the right in the car seat or in the high chair. They always do that. Wow, there may be something that needs to be fixed. ICPA, right, they're always saying, I hate adults, but I love working with kids. All right, you tell me when the 2-year-old walked in on their own in your office. Or who do you have to deal with? You have to learn how to deal with people. Okay, that's that other 3-legged stool. Common sense, love, passion with it. Okay? Leg checks, supine leg checks. Okay? I don't look for equalization, especially on kids. I look for change. Kids' legs can grow asymmetrically. One leg can be anatomically longer at one side, and then a few months later, the other side. Okay, look for change pre and post. Same thing with palpate and atlas TPs, by the way, guys. Atlas TPs. If you're trying to feel for prominence, you're going to be barking up the wrong tree because they can grow asymmetrically on kids. Look for which side is more superior. And that's not 100% either, but that's more consistent than looking for prominence. Look for which TP is up higher than the other. You're going to feel it that way, okay? Take a look at that, pre and post. Another supine leg check I love, this is from SOT, okay, newborn babies, okay? You take that newborn baby, their legs are supposed to be flexed, right? You take both the legs, extend, and let go. If one stays rigid in extension, that's usually PI line on that side. Okay, but there's lots of other things you look for, like hip dysplasia, things like this as well.